welcome. And it's lovely to see some new faces, especially as people are filtering in. I hope you feel very welcome, whether it's early in the morning, midday, or into the evening. It is, as Carolina Camaro says, it's difficult times, depending on where you are in the world, especially around COVID. So we do want to take a second just to acknowledge that these are not normal times, and that, you know, even we're grateful that you're making space for this, even though many of us are carrying lots of burdens, whether that's to do with our own personal parenting or family members, or definitely the challenges of our work. So we start today just acknowledging that this is hard work, and we're grateful to be together. We're grateful today to be talking a little bit about evaluation and a really innovative platform called CLEFT-Q, which Dr. Karen Wong from Sick Kids Hospital, we'll introduce her in a second, but she's online, ready to go. And it's amazing to think that we're already at our 19th webinar of being together. So if this is your first time, you're very welcome. As we go to the next slide, thanks, Niti. What we're doing today, just as we get started, it is lovely to be able to greet each other and know a little bit about where each other are coming from. And the goal, obviously, is to think about how these lessons we learned, this research that we're going to hear about today, applies to our own context in caring for children and families born with cleft lip and palate. So in order to do so, if you are able to, if you could change your name on your screen so that we can identify where you are and greet you by your name. We'll ask you to keep your microphone on mute for now, but all the way through, if you haven't used Zoom a lot, you really can keep track of chatting. So please do, as you see lots of people doing, greet the group. You can let us know where you're coming from, give warm greetings to everybody. And also throughout the presentation, we'll keep you on mute, but if you have a good point, a question, or a comment, feel very free to type that into the chat. We'll take note of that, and as we move forward into the comments and questions section, we'll try to weave those in. Also, you'll see Zoom, especially if you're not on a mobile phone but on a computer, they give you little reaction buttons. So feel free to try those out. We've got a variety of positive ways of encouraging one another. If someone makes a good point or has a good question, you can try those out, and it's a fun way of keeping engaged through all this. And at the end, as we mentioned, we will have a chance to discuss, and that's really a big part of the structure of our Circle of Cleft Professionals webinars, is that chance to ask questions and to offer comments from our own context. So moving quite along, today we'll do a quick update on the Circle of Cleft Professionals. As some of us who joined a few minutes early heard, there are some brand new participants, places like South Africa, who we haven't met before, so grateful to have you with us. We'll give you a quick update on what the Circle of Cleft Professionals has been doing. We'll hear from Dr. Karen Wong Riff, and then definitely we'll have a good amount of time for questions and discussions. We'll also point a little bit to some of us have seen each other relatively recently for a whole morning, a whole afternoon, or a whole evening, depending on where you are in the world, where we talked a little bit about solutions to those really difficult situations that we're facing as they relate to caring for kids with cleft in a comprehensive approach. So all those are online. We had over 140 participants, many moderators, roundtables. Facilitators are on this call, which is wonderful. And if you want to learn more about that, I invite you to check out the Circle of Cleft Professionals YouTube channel, which we can post near the end of the chat. And you can get caught up if you had to miss that, or if you'd like to share with your colleagues what you learned. Moving right along, I'll ask my colleague Niti, Transforming Faces Global Initiatives Manager, to walk us through a bit of an update on what's happening with the Circle of Cleft Professionals.
Thank you, Hugh. So what are our objectives of COCP? Our aim is to facilitate networking and collaboration amongst cleft professionals to communicate impact and the learning that's happening within cleft care, and that in turn will support the growth of local teams in implementing comprehensive cleft care. So now we have 390 members in our COCP community, belonging to 12 plus specialties within cleft care, who have joined us from 59 different countries across 6 continents. We would love to invite more CCC professionals into our community. So if you know someone who might benefit from or would be interested in joining the COCP, please invite them to apply for membership through our website. The COCP represents professionals from across all CCC specialties, including nutritionists, psychologists, social workers, nurses, and so on. A majority of our members, though, as you can clearly see, are surgeons and speech therapists who account for over half of COCP membership. So we are steadily growing as a community. These are the 59 countries around the world that all of our members come from. A shout out to the 10 charity organizations from around the world, all of who are deeply invested in supporting comprehensive cleft care in low and middle income countries. I now invite Hugh to introduce our lovely panelists.
Thanks, E.T. And great, as people filter in, wonderful. Glad you're with us. We're delighted to have Dr. Karen Wong Riff on the call this morning. She's a surgeon scientist at the Hospital for Sick Children in Toronto. She's also a member of Transforming Faces Medical Advisory Committee, so has a deep history with understanding the context of low and middle country contexts as it relates to cleft care. So her practice focuses on cleft surgery and microsurgery. She's also a researcher, as I mentioned, and that really is focused on the development and implementation of patient-reported outcome measures. And as such, she's the co-developer of the CLEFT-Q and FACE-Q Kids. Both are CIRC, so Canadian Institute of Health Research funded studies. She also has a cross appointment to the Institute of Health Policy Management and Evaluation at the University of Toronto. And so we're delighted to have her here. Karen, I think it's over to you. You can feel free to share your screen. And we'll make sure the technology works. And we'll be listening here. Again, if you have questions or comments along the way, please feel free to use the chat. But we will be spending a good amount of time up until the end of the top of the hour discussing how this works in our context, what the impacts of COVID might be, and really trying to pick Karen's brain a little bit on what she's learning as part of the CLEFT-Q project. Karen, please.
Thank you so much for the kind introduction. And for the invitation to speak today. I'm really honored. This is probably one of my favorite types of contexts to talk in, just because of the huge breadth of coverage that Transforming Faces and the Circle of Cleft Care professionals really provides. So as a disclosure, I'm a medical advisor for Similar Medical as well. I know Hugh already discussed this, but I also wanted to take a minute to acknowledge the fact that we are in a very strange time right now within this pandemic, and the fact that all of you are making time to be here to try and learn more, to take care of our patients better is really a feat when everyone is under significant, probably both personal and professional stress. And in thinking about this a little more, maybe one of the side benefits of the pandemic is that it's actually made our world maybe a little bit smaller. So it's nice to be able to connect with people on a maybe more regular basis. So the take-home message that I'd like to impart today is really that patient-reported outcomes are a key component in evaluating global cleft care. And I'm not talking just about low resource settings, but also in high resource settings. And if we take a step back first to think about, well, what exactly are we trying to accomplish in cleft care? For me, that moment came when I was working with my mentor, who is now my partner here at Sick Kids, David Fisher. We were talking about, what exactly are we trying to do for our patients? And if you think about it in an even greater context, this book sort of summarizes that really well. This book is called Thinking Fast and Slow by an economic psychologist who actually won the Nobel Prize for this work together with his research partner. And what he describes in this book is that people think using two different systems. System one is your initial immediate response that's sort of bred into you. So this is your fight or flight response. So, centuries ago, if you're walking along a path and you see a tiger, you think, oh, I'm scared of this tiger because I think it's going to attack me and I should run away. That, sort of sympathetic response that initiates, the fast heartbeat and the sweating and the fear is regulated by your system one immediate response. Then system two is your rational side. And this is what takes a little bit longer to kick in. So now if you say, if we go to a zoo, for example, and you see a tiger, your initial response might still be one of fear, but then system two kicks in and says, oh, but it's behind a fence. And so I should be okay. So I don't need to be as scared. This actually applies a lot to our patients. And, our patients often say they just want to be able to fit in and they don't want to stand out. And here's a quote from a patient that we interviewed in Kenya, where the interviewer asked, so before surgery, did you not like to look in the mirror? And she said, yeah, I didn't really. I never even used to wear makeup, nothing, because even if you put on makeup, don't help. So at least now maybe I can use a bit of gloss, something like that. Yeah. Because I didn't even want people to look at me twice, because maybe it not matter to someone who looks at you and looks at you again just to see how they see right, you see. It's very discouraging. And what she's describing here is really people's system one immediate responses to her appearance, and where people would look twice to see if they actually saw what they think they saw. And that's essentially what we're trying to change. But if that's what we're trying to change, then what are we measuring when we try and change that? And so then, it begs the question, how do we define success in cleft care? And I had to put in a little reference to our Canadian heritage here with something including snow, which I'm sure is not far off in our future here. But this is a really nice kind of illustration of what evidence-based medicine is really about. Evidence-based medicine and the quality of that evidence really depends on the quality of each of the building blocks, which are the outcome measures that go into creating the evidence. So without clinically meaningful and scientifically sound outcome measures, if we have one weak block here and it's not a good outcome measure and the science behind it is not good, then the whole structure sort of falls down and the evidence becomes poor quality. So then what exactly are we trying to do again? The World Health Organization has defined health as being a state of complete physical, mental, and social well-being, and not merely the absence or infirmity. So then it also means when we're measuring things, we shouldn't just be measuring the absence of disease or infirmity as an outcome. There are tons of different models of health that are out there. This is one of them, where health sort of depends on biological, social, and psychological factors that all combine together to give a person good health. And if we think about the measures that we typically use, standard objective outcomes in healthcare, in all of healthcare, not just in cleft care, but the ones that we most commonly measure are the biological outcomes. And those are important, but it doesn't tell us the whole picture. And oftentimes in cases where we're trying to manage appearance as well, those are more difficult to measure using these standard outcomes. So why is measurement important? Bill Gates said, I have been struck again and again by how important measurement is to improving the human condition. So if you can't measure it, you can't actually improve it. So if we look at the different type of clinical outcome assessments that are out there, there are several that have been defined by the FDA in the US, including patient-reported outcomes, observer-reported outcomes, clinician-reported outcomes, and performance-based measures. And we would argue that perhaps the patient perspective is the most important. So what are patient-reported outcomes, or PROs, as I'll refer to them for the rest of the talk? PROs are reports that come directly from patients about how they function or feel in relation to a health condition and its therapy without interpretation by a physician or anyone else. So these PROs can include every aspect of a patient's treatment outcome. People often think, oh, that, PROs are probably just for measuring quality of life, but they're not. They can measure symptoms, they can measure satisfaction, they can measure process of care, as well as health-related quality of life. So basically every aspect of a patient's treatment outcome can be measured by PROs. In this process, we run into a lot of doubt. So we get a lot of people asking us, can you really turn people's feelings into numbers in a scientific way? And as an example of that, this is a headline from the New York Times several years ago. And I'm not sure if you can see in that bottom left corner of the paper, it says the limits of cosmetic surgery. Now, this is obviously a realm that we are not talking about today, but it sort of sits in the same general spectrum. And they talked about a study that found only a tiny insignificant increase in attractiveness in people who had had cosmetic surgery. And so then, the whole cosmetic surgery world was up in arms saying, but people are paying these thousands and thousands of dollars for these procedures and they're not actually looking better. How can that be? But if you look at how they actually did this study, what they did was they sent photographs of people who had had cosmetic surgery, and they had other people, so not the person that actually had the surgery, they had other people rate their attractiveness on a scale of 1 to 10. And when they did that, they didn't see any improvement. Now, if you go back actually and ask those patients that are having cosmetic surgery, how do you feel about how your face has changed after cosmetic surgery? And it turns out, and this is a study done using the FACE-Q, which is a patient-reported outcome for adults, basically, in the appearance of their face, that post-operatively, there is a significant change in their satisfaction with their facial appearance. And not only that, but they also have a significant increase in their social confidence as well as their psychological well-being. So there is some benefit to doing this, obviously, from the patient's perspective, and ultimately that is who we are operating on. So sort of in response to this question, can you reliably turn feelings into numbers? We would argue, yes, you can, but you need to have good measurement. So patient-reported outcomes can be extremely powerful, and in different realms, they have shown this really remarkably well, almost more than that I thought would be possible with PROs. And PROs have been shown to measure surgical outcomes more precisely than standard observational techniques in orthopedic surgery. And most interestingly, I think, PROs have been shown to predict postoperative mortality better than subjective assessments, observational assessments, and blood work in adult non-cardiac major surgery. So this is kind of a huge step forward. If you can just ask a patient a series of questions and be able to predict what their postoperative mortality is, you can see that these measurements are actually, quite powerful, and there's something to them that we should be harnessing more. So if we look into the world of clefts that all of us are very familiar with, we know that clefts come in all different sizes and shapes and forms. And we also know that comprehensive cleft care is what we're all aiming towards being able to provide, which usually involves ideally a huge number of different specialties if it's possible. What we do know is that patients in low and middle income countries have less access to surgical cleft care, and that's obviously a problem in itself that we need to try and address. We do know also that there's a potential economic impact of repairing cleft lip and palate in low and middle income countries. And these studies have used disability weights and disability associated life years. And those measurements are they're very technical in the economic analysis kind of way, but they don't actually reflect what the patient feels, because there's actually no patient input that goes into determining what these disability weights and disability associated life years are. And so these types of measurements are good for comparing whole populations to each other. So for example, a population of patients that have cleft lip and palate to a population of patients that have club feet. So those are useful in that sense, but in terms of actually measuring differences within the cleft population, they're not quite as useful. We also know through the strong work of Transforming Faces and other types of organizations that building local capacity improves access as well as follow-up. And this is, one step in the right direction to be able to show that what we're doing is actually making a difference for our patients. So what we don't know, and this is what we don't know around the whole world, I would say, not just in low and middle income countries, how effective is the care that is being delivered? How well are we doing for our patients, and how do they feel about their cleft care? What's the impact of having cleft care on patients? And maybe most importantly, it's a key issue for us to be able to show what's the impact of not having cleft care? And because that's a huge advocacy piece for us, I think, to be able to show that not having cleft care is having whatever detrimental effects on a patient's health. When you look at the largest studies to date that have been done in a multi-centered fashion, Eurocleft, there's been so much work done in the UK that's really quite impressive to try and analyze this. AmeriCleft and ScanCleft. All of these studies really evaluated a single cleft type because it's so hard to look at our outcomes within cleft care. You saw the spectrum, we all know about the spectrum of presentation of clefts. And more importantly, maybe none of those studies were really able to capture the patient's perspective, which obviously is a huge missing piece, I think, in looking at our outcomes. So from this, we started the CLEFT-Q project, and the objective of this project was to develop a patient-reported outcome measure for patients with cleft lip and/or palate that would be clinically meaningful, scientifically sound, and also applicable to patients in high income as well as low and middle income countries so that we can use it around the world because there are cleft patients around the world. When you develop a PRO measure, there are three main phases. In phase 1, which is item generation, we answer the question, what exactly should we be measuring? In phase 2, which is called item reduction, we determine which questions are actually effective in measuring the concepts that we identified in phase 1. And then in phase 3 of psychometric evaluation, we determine whether or not the instrument actually works. So in phase 1, to answer the question, what should we measure? We went to these 6 different countries and we interviewed as many patients as we could to try and figure out how they felt about their cleft and how they felt about the treatment of that. And we ended up interviewing 136 patients. We did 136 interviews with 138 patients because we had 2 sets of twins that we interviewed with a number of different types of clefts. And eventually from that, all of that data, we came up with this conceptual framework, which basically describes what patients think is important with having a cleft. And that fell into these 3 domains of appearance, facial function, and health-related quality of life. And basically what we did was we generated preliminary items for questionnaires from all of this qualitative data that fell into these domains. And then eventually we developed preliminary scales. So then in phase 2, the focus was then to determine which of those questions are actually effective in measuring what we identified in phase 1. So in this phase, we went to 30 different sites in the 12 different countries that are identified here. And the goal of this was basically to determine which questions are effective in measurement. And so we had our preliminary scales on the left. So this is the face overall scale, where we ask, how much do you like how your face looks when you look your best, et cetera, et cetera. And I'll go into more detail than that in a second. But the goal of this was basically, let's cut out all the questions that don't work. So for example, how much do you like how your face looks in the mirror was a question that didn't really work in the psychometric analysis. So we took that out. And eventually we came up with this 9-item scale that works as a ruler. So on one end of the ruler, you have questions that are very easy for people to say yes to. So I think this rings true for everybody, not just patients with cleft, but how much do you like how your face looks when you look your best? So when you're looking your best, I think that's the easiest for people to say, yes, I like my face quite a bit. On the other end of the spectrum is a question that's much harder for people to say yes to, which is how much do you like how your face looks up close? And I think all of us would say, none of us really like when people zoom in on our pictures or come right up to your face to see how you look. And so this creates a hierarchy, basically, of all of the scales. And with this, we can create the good measurement that we were talking about. So the CLEFT-Q includes 12 different scales under the domains that we talked about. So the appearance scales of face, lips, nose, nostrils, cleft scar, teeth, and jaws. There are 2 speech scales. There's a speech function scale and a speech-related distress scale. And then there are 3 health-related quality of life scales: psychological well-being, social well-being, and school function. And finally, the eating and drinking scale didn't really work in the psychometric analysis. And so we did not include that as a psychometrically, as a measurement scale. Basically, it's more like a checklist. So it's important to note, I'm going to talk about some of the results that we found from this field test today. But really the key is that we ended up, getting these mean scores for all of the different scales. And this is a radar chart that allows us to look at all of the results in one image. And so you can see that the score, for example, for the face, the mean score is shown in that sort of spoke of the radar. And each score for all of the different scales is shown in all the different spokes. The key point, though, is that this is a cross-sectional study. So what we were trying to do was just get as many patients as possible to fill this out so that we could do the RASH analysis, which was the psychometric analysis, or the sort of pre-statistical science, to make sure that this instrument can actually measure properly. So this isn't a controlled study where we try to, recruit the same types of patients from every different site. This is just an extremely large sample of patients with all different types of clefts that we can look at. So these results are exploratory and they're not meant to be conclusive in any way. And there are some potential sources of bias because of that. So, patients were self-selected for participation. We didn't obviously force anyone into doing it. It was very voluntary. And then, it's also important to look at, what are the types of patients that present for care at every site. So in a high income country, you might have people presenting every few months for follow-up, and their overall severity of their condition might not be so bad. Whereas in low resource settings, people might not only show up for care when their situation is much more severe. So the patient populations that are captured between different sites is not necessarily the same. Now, when we looked at the analysis by country income level, we adjusted for things that we knew make a difference in CLEFT-Q score. So age, sex, if they're male or female, cleft type, and the timing of surgery. We defined timing of surgery as early versus late, with late being more than a year of age for the lip repair and more than 3 years of age for palate repair, which is already quite a loose description of late surgery, I would say. So looking at age first, maybe not surprisingly, we found that basically CLEFT-Q mean scores decrease over time with age. So as people get older, they become less satisfied overall with the appearance of their face. And this was a significant effect for all of the appearance scales with the exception of teeth and jaws. which is maybe understandable. Now, the right side of the chart, we included patients up to 29 years of age, but we didn't have that many patients from about 24 to 29. So that data is probably not the most reflective of, the entire population necessarily, but certainly the trends from 8 to sort of 24 are a little bit more consistent, and we kind of trust that a little bit more. When we look at mean scores by age for the speech function scales, you can see that speech function sort of increases a little bit in the teen years, and then it plateaus. And this had a significant effect for the speech function scale, where people did say that over time their speech function did improve. For health-related quality of life, this sort of pattern matched the pattern that we noted overall with appearance, which is that health-related quality of life for psychological well-being and social well-being actually also decreased over time, whereas there was no change over time with school function. When we looked at sex, so males versus females, and this is maybe also not terribly surprising, but females tended to rate their appearance lower than males did, with the exception of the teeth and jaw scales. And then they also described lower psychological and social well-being compared to males, whereas school function was the same. And interestingly, there was no difference in speech. And so speech function and speech-related distress were the same between males and females. Now, this is something that we knew where we would find a difference in cleft type, and we were kind of happy to see that the scores followed what we would hypothesize, clinically. So those with a cleft lip alone, so you can see the purple line here, tend to be quite satisfied with their appearance, although the ones that are the most satisfied with their appearance are those with a cleft palate only and no visible cleft on the face, which is maybe not a surprise. Those with the best speech were the cleft lip and alveolus patients. Patients with cleft lip only did not fill out the speech scales. And so it's not a surprise that those with a cleft lip or cleft of the alveolus, which is CLA, cleft lip and alveolus patients had higher speech scores than those that had a cleft of the palate. So the yellow and the red lines representing patients that actually had a cleft of the palate. Now, if we look a little bit in more detail and we look at the subtypes of those with just a cleft lip, you can see that those that have bilateral complete clefts, shown in the yellow line, sort of tend to score lower than those that have a unilateral complete cleft. And then the incomplete clefts, the green and purple lines, both bilateral and unilateral, are scoring higher, tending to score higher than those that have the complete clefts. This is found also for the cleft lip and palate subtypes, where those that have the complete cleft, so again, the yellow and the red lines, you can see are sort of more focused towards the lower end of the scale or the inside of the radar, as opposed to those with incomplete clefts that are further out on the radar with higher scores. This is maybe one of my favorite results that showed that as VO classification, so as the severity of the cleft palate increases, speech function and speech distress scores decrease, and this was also a significant association. So this is showing us basically that patients are able to tell us what their results are, what their outcomes are, and they do it in a way that's consistent with what we would hypothesize clinically. And so maybe this starts to tell you, maybe these patient-reported outcomes can do what we would like to do from an observational standpoint sometimes, but maybe the patients can tell them tell us themselves. When we look at timing of surgery with early versus late, what we found was that, and this is also maybe not surprising, the only significant difference that we found was in the face overall scale, that patients with late surgery showed that they had lower scores on the face overall scale than those who had early surgery. But for all of the other appearance scales, nose, nostrils, lips, cleft, scar, teeth, and jaws, there was no significant difference. Where there was a significant difference, and this is maybe also not surprising, was in speech function. To the right side of the chart, you can see the two speech scales, where those that had late surgery scored lower and reported lower speech function and more speech-related distress compared to those that had early surgery. And this also had an effect on their health-related quality of life. So psychological well-being, school function, and social well-being were all lower in patients that had delayed surgery. So despite controlling for all of these factors, when we look at mean scores by country income level, what we find is that there are still patterns that we can identify despite the fact that we've controlled for all of the other factors that we just discussed. So if you look very kind of generally at all of the scores here, so between high, upper middle, and lower middle income countries that we included in our study, scores in lower middle income countries tended to be a little bit lower. And if we look at the detailed, more detailed charts here, for the appearance scales, you can see that that pattern is consistent. And it turned out that patients in high income countries scored higher than patients in lower middle income countries on every appearance scale, and actually every CLEFT-Q scale, not just the appearance scales. And this difference was significant. For upper middle income countries, they also scored significantly higher than those from lower middle income countries on all of the appearance scales. And then there were some significant differences also between patients from high income and those from upper middle income countries. Most notably, those that were from upper middle income countries actually scored higher than those from high income countries on the overall face scale, and then lower on the nostril, cleft lip scar, teeth, and jaw scales, as you can see there. When we look at the speech scales, it sort of follows a similar pattern. So as we said before, those in lower middle income countries scored lower than those in high income countries on both the speech function and speech related distress scales. And those in lower middle income countries actually scored higher than those in the upper middle income countries on the speech related distress scale. And there was a significant difference also between the high income and the upper middle income countries on both speech scales. For the health-related quality of life scales, we see again a similar pattern. So again, the patients from lower middle income countries scored lower on all three health-related quality of life scales compared to those from high income countries. And the difference was significant between upper middle income and lower middle income countries for the psychological and social well-being scales. And then those from upper middle income countries scored lower on the social well-being scale only compared to the high income country, patients from high income countries. So that's a lot of data to go through very quickly, and I try not to focus too much on it because again, it's exploratory. So it's not meant to say that, you know, for certain everybody in lower middle income countries is doing worse, but it begs the question, you know, why is that, and what are we doing, and what can we do to help change that? And so typically when you look at the data that's been published in the literature, outcome measures in global cleft care have really been limited to more process related measures as opposed to actual outcomes. So those process measures include the numbers of surgeries completed and the wait times for surgeries. And those are both obviously very important indicators to show that people are actually getting more access to care. Complication rates are probably as far as the reports go in terms of actually reporting maybe clinically relevant outcome measures. But fistula rates, which have been shown to be higher in lower middle income countries compared to high income countries, you know, there are a huge range of fistulas out there basically. And so you can have ones that affect speech, and you can have ones that don't affect speech. You can have ones that affect eating and drinking and that sort of thing. So, you know, just having a fistula in itself doesn't actually tell you what the impact of that fistula is on the patient, which is, I think, another really important concept. So, you know, the biggest difference probably is the access to cleft care. And this is where I think that patient-reported outcomes can be really powerful in trying to advocate for comprehensive care. You know, having surgery in itself is not enough. And maybe it means that, you know, you need to have your speech and language pathologist available to the patients to be able to go through speech therapy. You need to have your orthodontist and your dentists and your ENT docs and your pediatrics colleagues and everybody to help really get this patient to the ideal position. And I think it's with patient-reported outcomes that we should be able to show this the best. There are some efforts underway to benchmark globally, and IHPME is one of them that I'm aware of. I'm sure there are others. This is the International Consortium of Health Outcomes Measurement, and basically they decided that they wanted to create a standard set of outcomes for a number of different conditions, and they picked cleft lip and palate as the first pediatric standard set to design. And they've included the CLEFT-Q in that. And the nice thing that this organization, you know, has its own issues in itself to try and actually implement this around the world. But they do focus a lot on patient-reported outcomes, and to say that, you know, it's actually the patient's perspective that is the most important. And as we moved further along, it became important to show, you know, does the scale actually do what we think it's doing? And this is an example of CLEFT-Q mean scores by need for surgery. So this kind of tells us that the scales actually do what we think they should do. So the red bars represent patients who need surgery. The yellow bars represent those that have had surgery. And the blue bars are those that have never needed surgery. So you can see that for those undergoing jaw surgery, those that have had surgery or never needed the surgery, those patients score higher than those that need surgery. And that pattern is consistent with those that are undergoing a lip revision procedure, a rhinoplasty procedure, and speech surgery. And so, we can start to get hints this way that the CLEFT-Q is maybe going to be useful for us in measuring those that need surgery and those that have had surgery and their outcomes, their actual outcomes. Ultimately, this is what I would like to see in my own clinics is people show up to my clinic and I can see what the mean scores are, which are in the yellow line, and you can see where your patient sits in relation to those mean scores for whatever cleft type that they have. So you can see patient A here is pretty much, measuring along the mean, but their speech is actually excellent, and they have very low speech distress with a very high score, and their function is overall very good. And you can see that automatically in one glimpse. And you contrast that with another patient who comes in who has very low scores relative to the mean in all of those for all of those scales. And you can see that this is someone who needs maybe a little bit more attention in whatever way. So this is, I think, a powerful way for clinicians to be able to see how our patients are doing very quickly in one glimpse. So in terms of the actual implementation piece, collecting patient-reported outcomes in any setting, whether it's high resource or low resource, is a bit of an adjustment. When we went to the low middle income countries, we had data that was collected either by a local team member or a research team member who spoke the native language. The CLEFT-Q scales have been translated into a number of different languages based on needs thus far. And basically our patients filled out the scales when they presented for clinical care. So they were showing up for an appointment, and that's when the recruiters asked them to fill out the scales. We administered the scales both on paper or on REDCap, which is basically an electronic version of paper. And it actually, when you do it on REDCap, it goes directly into a registry or a database, which makes it easy also that you don't have to transfer the numbers from paper to the database. And this depended basically on each site. So we used paper where it worked better and REDCap where there was internet access basically. For patients who are unable to read, we had team members read the questions aloud, which does create some risk of response bias depending on who is asking the questions. So if you have a member of the healthcare team asking those questions, it's probably not ideal because that patient might want to make that team member happy and give them a better view of how they're doing as opposed to if they were filling out the questions on their own. So it's quite important to make sure that someone who is impartial is there to help patients along. In general, when people administer patient-reported outcomes, they can either be captured before or after a clinical visit. And ideally for me, I'd like for them to be captured before. We tried in some sites to do paper mailings, but we got a quite low response rate from this because people will lose the paper, or they'll lose the envelope, or they'll just forget about it and they have to drop it off in a mailbox, which means that they have to have access to mail services to begin with. Ideally, it happens a lot more, I guess, robustly on email or in person, but electronic administration also requires internet access, which is something that we need to think about. Literacy is also something that we need to consider, and it might mean that this sending out the scales in some way, whether it's by an email or a text message, is not the best, depending on the situation with literacy in the household. If there's nobody around who can read the scales, then obviously the patients won't be able to fill them out properly. Some of the issues with capturing the PROs during a clinical visit, a lot of the sites that we went to were very crowded for space and didn't have a ton of extra room. And in those situations, we had to figure out where exactly are these patients going to fill out the scales. Obviously, they need internet access again if it's going to be done electronically. And a team member had to be available to assist if needed. So overall, if we go back to this view of what all the total outcome assessments are, it begs the question now, based on these results that we found, can PROs replace other types of outcomes in some settings? We have a lot of difficulty. There are so many arguments out there about, what's the best way to measure this and the best way to measure that. And oftentimes we're talking about ways for us to measure them as the healthcare team. And in some places, we just don't have trained people to do that, or we don't even have access to follow-up. And so it's really difficult to measure. So can patient-reported outcomes replace those outcomes in those settings? And if we go back to this slide again about the power of PROs, the potential of them is really astounding. And it really begs the question, what can PROs do in cleft care? And we're not going to know until we start actually measuring them. So the CLEFT-Q now has been licensed in more than 196 sites in 40 different countries. It's free for nonprofit users. And if anyone is interested, you can go to this website, qportfolio.org. It's a very simple license that you just need to sign with McMaster University, where we have it licensed. And then we give you the scoring charts as well as the scales to use however you like. So my final thoughts would include the fact that patient-reported outcomes are really a key component of measuring outcomes in global cleft care. And this data can be used to evaluate effectiveness and also to identify opportunities for improvement. So we saw that patients are maybe doing well with their appearance in some areas, but not so well with their speech. So then we can target our interventions to be able to improve outcomes where they need to be improved the most. And finally, in low resource settings, it might offer, PROs might offer a relatively simple way of measuring outcomes where you don't really need a trained person necessarily, because all you need is the patient and time for that patient to fill out these scales. So in closing, I'd like to acknowledge all of our partners around the world for their participation in the scale and also for our funding sources. And I hope that this will be the beginning of lots of conversation around patient-reported outcomes. I'd be happy to answer any questions. And thank you again for the opportunity.
Thank you, Dr. Wong. Wow, that was a lot of information. Lots to think about there. I'll invite, we'll keep it on the screen so we can see everyone. If you'd like to turn on your camera, if your bandwidth allows, feel most free. As always, we'll spend the remaining amount of time really discussing how does this apply to our different contexts? What questions do you have for Dr. Wong about how to move this forward, or any questions of clarification? How does this work in your own context? So give everyone a second to think about that. So I'll start us off. Dr. Wong, you mentioned, right off the top, the idea of how important it is to be able to measure something in order to move towards improvement. What would you say are some of the first steps, especially in low and middle income country context, of those teams that were moving towards better measurement? What were the first things that you saw, maybe, and even anecdotally, that they implemented in order to move towards using CLEFT-Q?
That's a really good question. Implementation is really the hardest part of this, I think. And really what it takes first is buy-in from everybody and engaging the stakeholders that are going to be using this information. Because it takes a little bit of time, and the logistics of actually getting the scales filled out is really the most difficult part. And so if everybody on the team is willing to come on board, then it will happen. And basically our partnerships grew out of people recognizing, hey, this sounds like something we could use. We'd like to participate. And then we were able to try and find the resources to help get everything started in those settings. But really, it's the stakeholder engagement that's, I think, the first step.
Thank you.
I had a...
Dr. Felicity, please.
Hi, Karen. Great talk as always. Thank you. 2 questions, if I may. One is, how reproducible is this on if the patient's having a good day and a bad day? So say if a little one's been teased at school, or if they've just had something nice happen. So that was one. And the other is, at the end of the day, what we all want is a happy, well-adjusted little child. And there are so many variables that play into that. So my question is, your parameters that measured school, psychosocial, and social, did you detect how those parameters correlated with face, scar, lip, speech? And did that vary from one country to another? Because you can answer that question because you've got such rich data. I'm interested in what is valued more in one culture versus another culture. That's what I'm getting at.
Yes. And to answer the first question about, it's basically test-retest reliability.
Yeah.
I didn't talk about that. Those studies have actually just been completed, but there is actually quite good test-retest reliability of the scale, which means that if you give them once and then you wait a few weeks and then you give it again, the scores tend to actually be the same or similar enough that we can be confident with the scores themselves. When we talk about the effect, there's this age-old question of what's more important for someone's overall health. Is it appearance or is it speech? Because sometimes the procedures that we do for appearance might sacrifice speech and vice versa. We haven't, I'm just in the midst of that analysis now, but basically, I think there is some cultural difference, but I'm not sure that it's related to cultural difference or if it's that patients haven't had, or that there are more patients that have had delayed surgery. So what we found, even in the qualitative section of our study, was that patients from low and middle income countries talked more about the issues with their speech, and they were more concerned with their speech than with appearance. It doesn't mean that they weren't concerned with appearance, but speech was more of a factor for them. And I think we saw that borne out in the results as well.
Thanks, Felicity. Thanks, Dr. Karen. Kathy McCann had a great question. We talked a lot about literacy as one limiting factor. Could you just walk us through quickly, at what age do patients start to be able to self-report? And what's your findings around that and using parents, et cetera?
Yeah, that's a great question. I should have included that here, but basically the CLEFT-Q is for patients between 8 to 29 years of age. So at 8, they can definitely self-report. Below that age, I think we need to use some sort of parent report, although I think for appearance, that is a little bit questionable because a parent's version or a parent's view of their child's appearance is often different from the child's, and we've seen that time and time again. But basically, the child needs to be able to understand the concept, I think, before they can self-report about it. And we do find that a lot of our kids that are below the age of 8 haven't quite registered a facial difference, if they have one, in the same way as those that have turned 8. And certainly we find the same thing with speech. So in all of the literature about patient-reported outcomes, 8 tends to be kind of the lower end for self-report.
Thank you. And that mirrors, I think, a question that Dr. Michael also mentioned about getting younger children engagement is one of the key challenges in a low-income country context. Thank you.
Yeah, that's a really great question. And I think what we're trying to do now, especially with the speech scales, I think those are ones that are adaptable to younger patients and by parent proxy report. And so those scales will be coming as soon as we can get them done.
Aha, so it's not a finished product. You've got it's ongoing, Dr. Wong.
Absolutely, yeah.
Hi, can I ask a question?
Suraj, please.
Yeah, okay. Hi, Karen. It's a wonderful presentation. Nice listening to you. My question is in 2 parts. One, at what stage did these participants come into the study, whether they were repaired lip or a repaired palate? Because this makes a lot of difference in the way they have responded to the question. So how did you classify your group in terms of analyzing and reporting? What is the youngest participant and what is the oldest participant who participated in this study?
So the youngest patient was 8. The youngest kids were 8 and the oldest were 29. And we recorded, have you had surgery? Do you need surgery? And will you never need surgery for those specific things? And then we also looked at, is your surgery delayed? And we gave kind of very broad definitions of delay. And so basically, even when you take out the effect of surgical delay, delay in timing, we still found those differences. But we did also find that those who need surgery, so those that have not had it yet, scored lower than those that have had surgery. And so it basically shows us that the scales are able to measure when someone needs surgery and when someone has had surgery. And it gives us kind of a threshold maybe to say, maybe if you're below this score, you're falling into the category where people need surgery. And that can help in decision-making moving forward as well.
Okay. The second part of the question is just for my understanding. I'm asking because there are many tools which are developing and evolving process, and then this should help in giving some translate the data to the comprehensive cleft care team? And if so, how will this data can be interpreted by the comprehensive cleft care team? One. And two, in many countries, we use insurance and many funding agencies support the cleft and all of that. Can the values which come out of these, can those be used as one of the criteria to determine and allocate funds for patients or most needed patients? Do you have any thoughts that we may get some information on these lines?
Yeah, those are great questions. So first of all, for cleft care teams to use, those radar charts that I showed are really going to be the most effective. So if you have a mean score, even for your own center, because I don't know that we need to be developing mean scores or using mean scores for, cleft kids around the world, because everyone's situation is so different. So even within your own center, if you had mean scores, then you can see your own patient, where they sit compared to those mean scores. And then you can see how they're doing compared to patients around the whole world if you want. That basically, I think understanding the data just takes time with the data. So the more you see, the more you understand what a 60 means on the facial appearance scale. In the beginning, 60, or what does that really mean? You can see what the mean scores are for those that need surgery and those that have had surgery. So you can see those that need surgery are sitting around 60 and those that have had surgery are sitting around 70. So over time, with using these types of scores, you begin to understand what those scores mean clinically. For your second question, I think that's a really important factor. So around the world, this whole concept of value-based healthcare is starting to really take hold, where we need to show that or prove that we're providing value. I think it's a little bit risky to associate cost with these outcomes, because not everyone is going to have a fantastic outcome for whatever reason. There will be complications, obviously. But I do think overall that, trying to advocate for our patients to say, look, their scores are sitting down here, whereas the mean scores are up here, and I need to do something about it. And I need the resources to be able to do that. So to advocate for our patients, I think the scores actually will be useful over time.
Thanks, Suraj. Thanks, Dr. Wong. I want to make sure we touch on a couple of these points. Erica was wondering about the influence, in a CCC team of feeding and nutrition, and how that might influence CCC score or CLEFT-Q scores.
That's a great question. So we purposefully did not include parents in the initial development. And I think that's a whole other piece that we need to touch on. So that will probably be part of the next phase as we start to look at patients who are representing outcomes in younger patients, where it has to be done by parent proxy. And feeding is a huge component of that. So that's another study. If anyone wants to start working on that, please be in touch.
Thank you. It sounds like a great point. Edwin in the Philippines was wondering if you could say, just comment quickly a little bit more on comparing PRO outcome evaluations with other kinds of comparative studies.
It's a great question. So there are very few other comparative studies to really look at. So when we look at data from maybe some of the bigger multi-centered studies, the outcomes that we're finding are it's difficult to compare, because there's no sort of before and after necessarily. It's just, these are the outcomes at this age. But I think moving forward, I think that's really key. So I'm not saying we should only be measuring patient-reported outcomes. We should be measuring them along with these objective outcomes. And then we'll develop this field of knowledge similar to what has happened in orthopedic surgery and in that study that showed the outcomes with postoperative mortality, to be able to predict. Then we can say, here's how CLEFT-Q scores correlate with nasopharyngoscopy, or with whatever orthodontic outcome you want to measure. And then it might be able to replace those objective measures in some situations, where access always to an orthodontist or a speech language pathologist, or even the aesthetic outcome, because we've always had so much trouble in defining what's a good aesthetic outcome. We don't really know.
Fantastic, thank you. And I think that might have been one of the more fascinating concepts for me, and I'm wondering a little bit about the group, but I don't know if you can comment a little bit more, Dr. Wong, on the idea that PRO, so patient-reported outcomes, could really almost replace the need for something that measures, a nasio endoscope, or some of these other technological tools that our partners report saying this is really hard to get a hold of, get training on, and everything else. Can you say a little bit more about that idea of PROs as really almost allowing people to move forward with outcome and evaluation without necessarily all the full complement of tools that you would have access to at Sick Kids in Toronto?
Yeah, I think that's the greatest power of them. And I mean, even for our own patients now, especially during a pandemic, we're trying to minimize our visits in person and do as much as we can virtually. And our patients here in Toronto come from all over the province, and sometimes they have to fly to us because they come from very remote centers far away. And it would be really great to have a screening tool eventually where we send them the scales, they fill them out, and then we see the scores. And if their scores are okay across the board, we say, you know what, you don't have to come in this year. I think we're doing okay. But if we see a score that's very low, then we say, you know what, I need to talk to you, whether it's virtual or I need to see you in person, or I need you to send me a photo. So I do think that that power is there, and all we have to do to be able to get to that stage is start measuring both the CLEFT-Q outcomes as well as these objective outcomes, and then do exactly what Edwin was talking about, which is compare them and see, you know, what's better in or what's at least equivalent, if not better, in measuring these outcomes as remotely and as simply as possible.
Amazing, thank you. And that, again, you know, obviously as we're all looking at resource constraints, that seems like the ability even to say, please you don't need to come in right now. I mean, that is such an asset, obviously, in some of the countries in which are represented here, where travel is as much of a challenge as it is from remote communities in Ontario. Another question quickly that came up from Dr. Carolina Camaro in Northern Argentina, which I was wondering about also. I mean, many of the professionals on this call represent, you know, one of the only or few comprehensive cleft care teams in their whole region. So has there been work done in comparing, in a low and middle income country context, someone who had access to more of a full comprehensive cleft care approach versus someone in a country who had access to surgery only, and looking at their scores?
It's a great question. So what we did basically at the centers, and I very purposefully did not identify any of the centers just for the purposes of the study, but there were a number of patients in, actually almost most of the patients in the low middle income countries that did not have comprehensive care. And so that's why, you know, I post that picture of saying, you know, maybe if these kids had access to all these other specialties, and that, you know, surgery wouldn't be the only thing that they had, they would have, you know, been able to access all those other specialties that would maybe have increased their scores. The upper middle income countries, the access was variable, so that we had some sites that had great access and some that did not. And I think that probably did bear out in the scores as well.
Wow, amazing. The time has flown. I do want to honor people's time. Niti, if you could just show us our last slide. Thank you so much for your really thoughtful responses to Dr. Karen Wong Riff. We're so grateful for you. If we'll go to the next slide, please. There we'll say, so if this conversation is interesting to you, we do have a platform called Slack where you can ask questions, get some results. We'll also be posting a video of this. Dr. Wong has graciously agreed to let us post this both on YouTube and in Slack. I think there's a lot of information there, especially if you're part of a comprehensive cleft care team or emerging towards a team. You might want to have your colleagues watch this and start thinking about what are those elements that we can start to measure, even as a first step, in order to demonstrate improvement. And then also, as Suraj was asking about, I mean, how we start really making that case for what it means for funding, what it means for prioritization of giving patients and families access to a fuller example of comprehensive cleft care in order to show that they make better rehabilitation, full rehabilitation, are so confident in moving forward in being full members of society. So I think there's a lot of questions to unpack there. There's so much, we just scratched the surface today. But please do join Slack if you'd like any support with that. You can email us at info@cleftcircle.org. The email's there. We'll get you started. And if you have other ideas for other webinars you'd like to hear about, or even taking this kind of thing further, we'd love to hear that as well as we start to plan for the rest of 2020. And then obviously, as we're all looking forward to lots of progress and a new world order in some ways, hopefully, of more stability and ability to care for patients in 2021. So thank you, everyone, for joining us today. We're so delighted. And yeah, feel free to greet everyone. I won't cut us off right away. You're welcome to go, but please feel free to post any more questions or comments in the chat. And we're grateful again to Dr. Wong for giving us her time today. Thanks, everybody.